Okay, well, I think that recording in progress is a sign that we've, let folks kind of stream on for a couple of minutes. I'm sure people will still be logging on, but wanted to get right in. My name's Alison Gaye. I'm a senior manager of drug user health here at NASTAD, working on our COVID-19 project. I just want to say good morning and welcome y'all for day 2 of our Southern SSP Institute. It is so wonderful to have y'all. We had so many great conversations and wonderful discussions yesterday, and we're looking forward to a second day of just as many contact points, talks. I mean, we just have so much to share in Southern harm reduction, and we're really excited that y'all are here to share that back with us. So yeah, excited for our second day of discussion, strategy, inspiration, and solidarity. Across the South, Syringe Service Programs can be faced with limited resources, infrastructure, and varying levels of or varying levels of funding and support. But we know that y'all do so much good work with what you do have. And so it is so inspiring to be down south, to see the harm reduction programs day in and day out, and to talk to y'all. And some of that kind of lack of funding and support is starting to change. While the rollout for some of these changes hasn't been ideal, I think we can all kind of agree on that there's been some large grants that have been announced that maybe weren't as accessible for syringe service programs as might have been hoped for in the planning. It is a good sign that funding is coming for harm reduction, and that is increasing. The American Rescue Plan, while being somewhat controversial in the news, did have specified harm reduction funding, which to my knowledge was the first time we had kind of seen that. And the first time we had seen that funding that didn't have some of those restrictions that have really, really hindered our programs from growing, our services from expanding to meet the needs of our communities. Christine Rodriguez, who you'll get to hear from a little bit later, and myself are currently even working on a large pass-through grant funded by the CDC specifically for syringe service programs. And while that's COVID specific, we do hope to learn a lot more in regards to what this funding can do and how we can structure that to really be as supportive as possible. I know there's also a growing number of health department staff and bureaucrats on this call, on yesterday's calls, and at these institutes in general, which really can be a positive sign that, we're getting around, we're circling the wagons and trying to figure out how we go forward in a way that really can strengthen our programs and provide the services our communities need. So as we approach this landscape where funding exists and is growing, but not always in a way that's directed by our programs, by our SSP staff, let alone the communities we serve and the communities of people who use drugs that we identify within. How do we advocate for ourselves, for our communities within this funding? And what do we do when we've been scraping and scrounging for so long in this field, when we've defined how our services work, what our policies are, what data we collect, and what boundaries we set for our programming? And now with new funding, there are new stipulations, new requests arising. So what do we do from here? So I am really honored to moderate this panel with Christine Rodriguez, Zach Ford, Tyler Bartholomew, and Tim Santamour, of just incredibly smart and experienced harm reductionists who have so much knowledge in this topic and all other topics regarding harm reduction. I am lucky to get to learn from y'all whenever we get to talk, and I'm so excited to kind of just now that I've given y'all my few minute spiel, to just sit back and let y'all take the mic, take the spotlight. And so in the interest of kind of digging right in, I think I'm just going to kick it over to y'all with a couple of questions and kind of get the conversation going. We want this to be, as it's our opening plenary, you're all sitting in the large conference room around round tables with white tablecloths. Maybe there's even a little table in the back with some croissants and muffins and stale coffee from the Hilton. So as you're kind of grabbing that, sitting down at your table, we're going to look to be a little bit more conversational, kind of kick it back and forth, and try to share what the 5 of us have really learned in this recently with the new funding and previous to that funding. So with that, I would love to give it over to you, Tyler, first, and kind of if you could kick it off, in Florida, we know that syringe service programming can be somewhat difficult. There are some particular stipulations within your legislation around funding and how to use that funding. And so I'd love to hear, and I'm sure everybody else on the call too, would love to hear some of your thoughts about what considerations are necessary for building and structuring funding in an environment where it could be hostile or less than supportive, both politically and from the infrastructure level.
Yeah, absolutely. Thanks so much, Alison, and good to see everybody, and good afternoon. My name is Tyler Bartholomew. I'm assistant professor at the University of Miami School of Medicine, and also the director of research for the IDEA Miami Syringe Services Program. I've been working with IDEA Miami since they opened the pilot project back in 2016. I think everyone knows in Florida, the law is very restrictive around this topic of funding. So this is great for us to talk on this panel about how these top-down approaches and these policies made at the state level, and now what we're seeing in Florida on the local level, is really impacting how funding is used and utilized and what it can go towards. And so in Miami in particular, I'm gonna stay with Miami because I have Tim here, who's our colleague at the Florida Harm Reduction Collective. We have such an incredible movement and cohesive and collaborative collective movement going on in Florida that I'll let him talk as well about the state of the state when it comes to funding. But for us in Miami, funding has always continues to be a challenge and has been a challenge in the past. With the state prohibition on funding for syringe services programs, we have had to do a lot of hardcore grant writing that everyone is very familiar with in the harm reduction community when it comes to trying to get money to purchase supplies to run the foundational part of the program, which is the syringe access. And so we continue to face that day in and day out here in Miami. We see that across the state as well. I think that's probably the biggest barrier to getting a program open. Right. In Florida, we have this legislation that has counties have to pass local ordinances to implement these programs. And a lot of times when you go to the county, they ask about what's the funding tied to this. They can't provide any funding for the programs. And so funding is the core element of all the phases of implementation. And so for the county commission to get on board, they want to know funding. For you to open the door, they want to know funding. And for you to sustain your program, it's always about funding. And so it's great to see grants like the SAMHSA grant come down and more federal dollars looking through this and having pass-through dollars that Christine's going to talk about that can go directly into the programs for these aspects of funding the syringe access. For Miami, we've done a lot of work around the wraparound services. And so we're much more of a medicalized model, I would say, than other programs across the country. And so at this point in time at IDEA Miami, we probably do 5 to 10% of what we actually do on a day-to-day basis is syringe access. A lot of the wraparound services of testing, HIV testing, Hep C testing, on-site treatment for HIV, on-site bupe clinic that we have through telehealth with our providers here. We have all these other wraparound services that are offered on-site at the program that seem to not have issues when it comes to funding the program. And so I think there's distinctions, and we've been able to compartmentalize that. This is ancillary parts of the program. This is a core piece to the foundation of the program, but these are ancillary wraparound services. And so we've been able to get funding from the Department of Health and other organizations and agencies to fund programming that's not the syringe services program. And so keeping the things separate, we have 5 shipping containers that are on lot here doing SSP now. And so the different shipping containers have different, what we call services. And so our SSP is in one trailer, and then the rest have all the different wraparound services with the community engagement team, with some of the research studies that we have going on. And so we have everything kind of compartmentalized physically, but also on the back end too, where we don't have any questions regarding where the funding is going and who's using the funding and all those things. We've had to do so much grant fundraising, private donations that go into to fund the syringe access part of it. And that is just, a constant thing that goes on all the time. That's not something that stops. We're very much looking forward on how we can work together collaboratively in Florida to sustain programming for these programs for that core piece of syringes that every program has an issue with. And so that is our goal, is to tackle that barrier and create an infrastructure that can sustain moving forward a state that has a network of SSPs that don't have that issue when it comes to funding. So we've done our best to facilitate funding opportunities to the programs through our networks that we have with Gilead Focus programming, where we've been able to fund HIV and hepatitis C testing at all the expansion sites. We've been able to try to give as many supplies as we could to the program so that there weren't any questions around where are the supplies coming from, how are you going to fund the supplies. We wanted that to not be a barrier to open your doors. And so we offer a 3-month kind of starter kit to programs that are looking to open so that they can open their doors and then figure out the funding mechanisms later. But this is such a timely topic, obviously with the SAMHSA grant and everything coming down from the government, but also there's a lot of cool and innovative things that we're doing here in Florida to hopefully build a sustainable network to sustain these over time. So that's my spiel for now, and I'm gonna kick it back to you, Alison.
Thank you so much, Tyler. Yeah, I'm so glad you brought up some of those points. Like, they're something I think about a lot, and I'm sure a lot of other folks out in the room probably do too. And especially that point on infrastructure. I know from personal experience when I was at the program level, coordinating a syringe access program, I thought a lot about how much money we needed to do what we needed to do, but we had so much other stuff going on that we didn't necessarily have the infrastructure to build on to find that funding, right? And so I want to kick it over to Tim, I believe a little bit northern or a little bit more north of in Florida, about some of that infrastructure that you're building. How do you support some of those new programs to to accept that funding, to be able to build off those 3-month starter kits? And especially too, and this is a little plug for one of the projects I'm working on, is somebody who got to review the grant applications for the COVID-19 SSP grant. I saw that y'all had a number of applications from Florida, and it was really great to see, I believe, 9 programs apply and be able to join our cohort. So I'm really interested in hearing how y'all kind of built that infrastructure and how you support those programs.
Good morning. Thanks, Alison. Morning, folks. My name is Tim Santamour. Just a little bit about me. I would prefer to be in the bar at the conference than in the conference room sitting up on a podium or something. And anyone that's ever been at a conference knows that's where you'll find me. I've been around harm reduction for more than 30 years now, starting in Buffalo, New York with Underground Exchange, working with a hospital-based program there, moving to New York with Lower East Side. I did a stint with DanceSafe as executive director back in the early noughts. 3 years ago, I retired, moved to Florida, and for years had been talking about starting Syringe Exchange in Florida. And thank God, Hansel Tukes and his cadre of med students and moms and stuff got that done, so that all that work was done before I got here, and I could focus on what I really like doing, which is networking and building and supporting programs. So Florida Harm Reduction Collective has been around for about 2.5 years now. We started as a small group of folks, and Vera, my cat, is going to join us. Started with a small group of folks meeting at Rebel Recovery, which is a combination recovery community organization, syringe access program in West Palm Beach. In that group of folks, from the onset, we were very intentional about who we were inviting to the table. Started by reaching out to Sex Worker Outreach Project in Tampa, in Orlando, and making sure that sex workers were at the table. Reaching out to other recovery community organizations, IDEA, Black Run organization, Dream Defenders in Orlando, to make sure they were there. And just kind of like, it's such a pain. Just kind of making sure that everybody was at the table from the onset, so that we could really, have those open conversations about mutual aid and how to support each other. So the structure that we've been working on here is one where the collective seeks to take on the administrative tasks for organizations. The way that IDEA is set up, where we have to pass a county ordinance in every county to have a syringe exchange in every county, the kind of possibility that that would mean we need 67 different organizations across the state to have accessible syringe access programs for folks was kind of daunting. That's 67 boards, 67 executive directors, 67 program directors. It just, really looked hard to accomplish. And along with that, 67 governance documents, 67 sustainability documents, all that kind of looked like a lot of lift. And so what the collective kind of decided to do is we would become the 501c3 organization for that. We would take care of those administrative tasks, and we would seek funding kind of collaboratively and cooperatively across the state. And that's what Alison's referring to. One of the examples was the COVID grants that have just come out. When they came out, we had a quick phone call. We all discussed them together. There were probably, I think, 14 or 15 people, different programs on the call. We discussed, what the grant looked like, what the deliverables with the grant would have to be. And then we sat down and broke out grant writing on the 3 tiers based on the programs best suited for those tiers. So I know that we did get, I want to say 4 tier 1s that I can think of. And we got 1 tier 3, which went to IDEA Miami. So it was that kind of sort of mutual aid, letters of support from organizations for the grants. I think we collected something like 21 different letters of support for those, in working together to make sure that funding goes where it's going to kind of be best utilized. We have also been able to establish a compensated community advisory board using sort of the same structure, reaching out to different programs across the state, recruiting community board members who are compensated for their expertise and their time. And then the community advisory board talks back to the collective structure and says, hey, this is what we would like to see as a direction for the collective and as a direction for the programs under the collective, whether they be something like IDEA Miami or one of the more traditional treatment or recovery community organizations like Rebel Recovery. And so, the community board really drives that structure. They really drive the technical assistance and the trainings we offer. We have 2 trainings coming this weekend that they specifically asked for, one in HIV self-testing and one in wound care. And recently, based on the Community Advisory Board's request for kind of what support they need, we applied for the CDC Foundation home self-test HIV self-testing kit grant, and hopefully we'll get that so that we can actually pay the folks doing the work. And that's also part of our structure, is to pay folks to do their work, to hire them, to put them on payroll, to get them benefits, to get them work histories. We aim to hire people who use drugs or people with recent history of using drugs, and kind of support them in that, get them back on track. I could kind of go on and on about this structure because I think it's been really helpful to work with IDEA Miami. Our SAMHSA grant includes working with peers on career advancement, identifying where they would like to be. And we couldn't do that if we were just, one needle exchange program in one county. It really takes to me the cooperative mutual aid work across county lines and across program lines, across silos to make that stuff work. So that's kind of what we've focused on and where we're at now.
Thank you so much, Tim. There's so much in there too that I think is so important to take back to our communities, to the programs we're working with. I mean, that compensated community advisory board structure is, I just don't even know what to say. I mean, that is something that can be used everywhere, right? Being able to really advance the voices of the folks that are receiving the services.
And that's what I'll say, that it's meaningful. It's not just a community advisory board to have a community advisory board. We're really, and I'll say this about Idea Miami too, they're listening to what the CAB is asking for and going out seeking the funding to support what the CAB would like to see implemented. I think that's important. You can have a CAB and give them money, but if you're not listening to what they're doing, you really don't have a CAB.
And you're sowing those really important seeds by providing that professional experience, by giving somebody that work that they can put on their resume. We know that public health has often relied on internships and volunteerism, and that isn't always, possible or attainable for folks that we serve, whether that is LGBT folks or people of color, people who use drugs who may not have the financial flexibility to do an internship. So I love hearing really that professional development, getting folks to be into the field so that they're then spreading more of their knowledge, more of their expertise, and really pushing us in the right direction. With that too, maybe I'll move a little farther north up to our colleague Christine at AIDS United, because what do we do when we are offered some funding, whether it's from the state or the federal government? How can we pass that funding through? And what considerations and structure do we need to build to ensure that funding is effective, low threshold, and workable for the programs?
Yeah, thank you, Alison. Good morning, everyone. Good afternoon. It's lovely to be here with you all. Christine Rodriguez, I work at AIDS United. I am currently the Senior Program Manager for Harm Reduction there. We focus on strategic grant making and technical assistance for SSPs out in the field across the nation. And what that looks like right now is administering the Syringe Access Fund, as well as Alison mentioned, partnering with NASTAD to administer one of the tiers of this CDC COVID-specific funding opportunity for SSPs. And so operate as an intermediary funder, passing through private and federal dollars to programs on the ground. And so, I would say a few things about structure. And first, I think, is making the argument for that structure, both to larger foundations and to the federal government, that there is immense value in having an intermediary funder execute these grants as folks with expertise in harm reduction, as folks with relationships in community, as folks who are invested in trying to create a funding model that really works for folks, because of the infrastructure sort of limitations that I think, have been touched upon earlier. So I think some of it is about making that argument. And once we have funds to grant, I think, there are a few things that we have put in place and are looking to improve around effective funding for SSPs. One of those being utilizing a participatory grant-making model, especially around the review process. And so really ensuring that applications are evaluated by actual experts in the field, people who are familiar with SSPs, have run them, have worked them, know what to look for, know when a program is truly adhering to sort of harm reduction philosophy, meaningfully including folks who use drugs in employment, in feedback to the program, and those sorts of things, that really sort of know what to look for and can provide context for programming around the country. I would also say that some of it is about trying to simplify the application process for folks, right? So that was a huge barrier with these SAMHSA grants that have come out, going directly from the feds to programs. As Tim was mentioning, if you're just a single syringe exchange, it can be incredibly daunting. time to put them together is often prohibitive. You have to do these registrations for all these, numbers and all of these things that not everyone has the time to do, and often preclude you from accessing funding that is meant for you, right? So really trying to assign sort of evaluation points to substance over style, right? Making allowances for some mistakes that aren't necessarily substantive, but might just be because someone's not an experienced grant writer, right? Like if you send an application that has a 500 word limit for some funders, if it's 510 words, that application's not even considered, right? And trying to be a little more flexible, I think, with our process, not being too overly strict with requirements and allowing for a little grace, especially for programs that have been started by and for people who use drugs. We don't all get grant writing training, right? But trying to make that grant writing training available. I would say that we also try and do this around reporting and really trying to ask for meaningful data that we're actually going to use and report back to existing or potential new funders, but not asking for more than that. Not asking for data that we're just curious about, but isn't going to be used for anything in the end, right? That we utilize each part of the reporting that we're asking for, because we know that that's labor and time that you are, not necessarily having a ton of. So making reporting as infrequent as possible while still doing our due diligence around programmatic progress and proper use of finances and things like that, but trying to trust our programs and come from that sort of trust-based perspective that you need the money, we're giving it to you, we assume you're going to do what you said you would do with it, let us know how it's going, but then sort of stepping back and letting you do the work. And for our, in particular, our private funding like Syringe Access Fund, where we have freedom versus sort of federal funds that come with a lot of stipulations and restrictions and things like that, really offering as much flexibility as possible in the use of funds within the broad intention of the initiative, right? So allowing for purchase of things that other grants and often government grants don't let you buy, actual syringes for your syringe service program, pipes for your stimulant smokers, like whatever the case may be, staff time, your mobile van, whatever is coming up that you can get your needs met through that funding. And on the backside, sort of through the life of the grant, as much as we have the capacity, offering technical assistance to really support, some of those infrastructure needs and also your programmatic goals, because we're as invested in your success, maybe not quite as you are because you have the relationships with folks on the ground, but we're incredibly invested in your success. And so I think lastly, I would say, and then I'll stop because I'm really interested in your questions. I would say that it's also internally really important for us to not get complacent around just doing sort of what's been done, in case there's a simpler way or something that would make your lives easier, to sort of take the time that we have to like review our process, get feedback from you about like what worked, what didn't, what kept you from applying, whatever the case may be, so we can sort of smooth this out and make it as easy as possible for folks. And really, collecting your success stories to uplift those to funders, because the more we can fundraise, the more we can get out into community. So that's sort of what I'd say around low thresholds, workable for programs and things like that. But really interested to hear what is on folks' minds later in the session. Thank you, Alison.
Thank you so much, Christine. So many super important points. And I see that folks in the chat are agreeing with me when I say this, that perspective on data collection is so important, right? What are you going to use the data for? Needs to be something you need to answer before you start asking a whole community this data point. So love hearing that. And also that technical assistance to help keep building the programs up, kind of like how Tim was talking about building our communities up. So kind of working our harm reduction principles through each step of this process as well. And so it's really awesome to get to hear y'all speak on this and to get to be part of this, kind of chain that we're building. And so with that, I want to kick it over to our neighbor up north, Zach, to ask about, what considerations do you put into play when you are collaborating with a state or city health department? Many of us down south are starting to see this funding coming from health departments, both state and local. And so what kind of lessons can we learn from y'all up north on how to manage those collaborations? How do you ensure that your relationship with funders is symbiotic, that we're all getting what we need so that we can make this a sustainable system?
Yeah, thanks so much, Alison. And thanks for having me. It's really great to be here. So hi, everyone. My name is Zach Ford. I use he, him pronouns, and I'm the Director of Development at Vocal New York, and I'm based in Brooklyn. I know that isn't the South. I was born and raised in Kentucky, if that is helpful at all, and I'm really happy to see some of the Kentucky folks on the call today. So I've been working in harm reduction since about 2015 and was previously with the Syringe Access Fund. So I've got the experience, on both sides of harm reduction funding, like giving the money out and also requesting the money. But I definitely am going to get to some of the questions Alison asked me to touch on, but did want to share just a little bit about Vocal because folks in the South may not know much about our work and kind of set up our structure before I get into some of the specifics of our funding. So we are a statewide grassroots membership organization that builds power among low-income people affected by HIV, the drug war, mass incarceration, and homelessness. And so we do community organizing, leadership development, advocacy, direct services, participatory research, and direct action. So I think we were started in 1999, and first and foremost, we're really started as a grassroots organizing power building group. And so, I'm sorry, the chat was popping up. I got distracted. But after we launched in 1999, we were really focused on fighting for housing for people living with HIV in New York City. We were called the New York City AIDS Housing Network back then. But our work has really expanded since then. In 2009, we added harm reduction services, including syringe exchange. And that was really a dream of two of our co-founders. So we were co-founded by two men who publicly self-identified as Black men who used drugs who were living with AIDS. And they really wanted to see those harm reduction services come to life. Unfortunately, they both passed away the year before we were able to launch them. But Joe Bostic and Joe Capostani, who founded Vocal, really kind of cemented that we would eventually start doing those harm reduction services. And so as our work has expanded, right, like outside of the community organizing just around housing for people living with HIV to become much broader than that, kind of across the criminal justice, social justice like housing, drug user health intersections, we've grown, and so has our budget, right? So, I mean, we started out as like purely like grassroots coalition, like no 501c3, no formal anything, and our operating budget this year is around 4 million, depending on how things go this year with my job, but that supports all of our work, right? All of our community organizing, our power building, our direct harm reduction services. Our actual SSP budget is around 1 million. And we've got around 50 staff members. We're spread out all across New York State. And I think like one of the things that really makes us different, I think, than a lot of programs in places outside of New York State is that most of our SSP budget is city and state money. I would say like 95% of the money we get for our harm reduction services comes from contracts with the New York City Department of Health and the New York State Department of Health. When you look at Vocal as a whole, like 50% of our budget comes from private foundations with awards ranging for like 15K all the way up to 500K. Around 35% of the overall budget comes from government funding, and that's almost exclusively for services. And then we get like 4% comes from corporate income. So that's, our pharma friends. And then lastly, the 11% comes from individual donations, which I say because like, I'm gonna touch on that later, but that those sustaining donors, those one-time donations, fundraising events, like those kinds of things are really important. Like we brought in almost 600K last year from just individual donations. And that's just like general operating funds that you can do whatever you want with. And so I think that that's like a really important thing to consider when you're doing fundraising. But like I mentioned, harm reduction services are funded almost entirely through city and state contracts. We're really, really fortunate to operate in an area that is relatively supportive of harm reduction. I think the New York City Department of Health and Mental Hygiene has supported harm reduction for a really long time. They've got some really great folks that work there. They do a good job at funding the work in the city and really allowing for relative autonomy for programs. I think this definitely isn't something that happened overnight. I think that there's been a lot of, like decades of education and getting like city officials like to come around to harm reduction and seeing its value. And I think like from my time at the funders table, like I know that a lot of programs have a lot of hesitations around receiving government funding. I know that there's things like application barriers, reporting requirements, auditing stuff, more oversight, less autonomy. And I think we've, all of that's valid. And I think that like we at Vocal have certainly experienced our share of issues. But something I'd like to remind myself here that I think is really useful is to not let perfect be the enemy of good. And I think like that relationship between a community-based organization and a government entity is never going to be perfect. There's always going to be some tension there. I think just like the realities of the work that we do, especially when we're working with the communities that a lot of our programs work with. The health department, like all our health department people on here today, we love you. Thank you for being here. Thank you for being awesome and helping us. But like, they're never going to do everything exactly like we want them to do, right? And I think that like once we accept that, we can kind of go from there and start building those relationships. And I think like, especially in areas that are only recently starting to see government dollars or aren't even yet, like that's a lot of education and relationship building that has to happen. But I think like the ability to truly scale up harm reduction services has to include resources from the government. And so like, just as an example, recently New York City sanctioned overdose prevention centers or supervised injection facilities. And so Vocal has been part of this conversation for years and pushing for this. And we're going to be opening one later this year. But when we finally got the green light from city officials, they were like trying to force us to open immediately. And this was something that like the outgoing mayor was like, I want to be the one to say that we did this, that I did this in New York. And so like the timeline was rushed. It was messy. Proper protections were not in place for staff of the SSPs or for our participants. So I'm talking about like really critical things. Like we had no written commitments from the DAs of like the 5 boroughs that they would not prosecute staff or participants. We had no commitments from NYPD officials around the city that they would not arrest our participants or our staff, like really critical things that we needed that the city was like, open tomorrow. And it was like, we can't do that. We won't do that. We're not going to jeopardize the safety of our participants, of our staff, of like these organizations that we've built that provide these vital services. And so I think like, we pushed back, we said no, we made our demands, we said we will open these things because like we want to, obviously, but like we need to know that like our participants are going to be safe, that they're not going to be arrested them like coming in, going out. We need to know our staff are going to be safe. And so we pushed back until all of our concerns were alleviated. And then we were able to move forward, and Washington Heights Corner Project and New York harm reduction educators were able to open 2 sites last year that have been doing amazing work. And then like Vocal and a couple other orgs will be moving forward this year with opening our sites. So I think like when it comes to government and health department folks, I think like also keep in mind, and this is something that we saw, that like our health department people who like work on the harm reduction side of things were doing everything they could to support the community-based organizations, but like they were getting all kinds of nonsense from like the mayor's office. And so like, I think it's kind of helpful for me to remember that a lot of times, like the folks that we work with directly at the health department are getting orders from other people and like are trying to do the best that they can. And so like, you know, there were all these moments of like pushback and tension and like negotiating. Ultimately it worked out, but I think that like when you're working in those spaces, it's important to remember that that like the well-being of your participants, like the safety of your participants, making sure that they have access to the services they need, but that like nothing bad is going to happen to them because of like ridiculous like government oversight or overreach, and making sure that like that's really at the forefront of what you're doing, what is really critical to kind of like giving you the courage to really push back on your city. And honestly, like in a situation like that, like the city was like, we want you to do this, but we're not giving you any money for it. And it was like, then we're going to do this on our terms completely. So another piece of advice that I always like to push around stuff, and I'm going to kind of shift from like government stuff just to like grant writing funding generally, is that it's like perfectly okay to not apply to a grant. And I want to like acknowledge and recognize the privilege that comes with being able to decide not to apply for a grant. I know that not every organization is at that stage in its evolution or development. But I do encourage folks to really, truly evaluate whether a specific opportunity is worth the effort of applying, whether staff will actually be able to carry out the deliverables. So when I evaluate a funding opportunity, there are many questions I ask before we decide. Looking at things like, what is the actual application process here? Is it too intensive given the amount of funding available? Like if I'm only going to get $5K, I'm not going to spend like 2 weeks working on a proposal. Do we have the time to create thoughtful, compelling, competitive application? Or are there other organizational priorities that's really going to take away from our ability to do that? And if so, maybe we need to wait on this one. I think looking at what the actual project is, whether we have appropriate staffing to carry out the deliverables, or are we going to need to hire? If we are going to need to hire, is the opportunity providing enough funding for us to do that? Will the positions be sustainable? Is this one-time funding? Is it multi-year? And will there be opportunities for renewal? Looking at things like, is the project something that our participants have expressed as a need, or are we just chasing money here? And do we have adequate infrastructure to support the project? And if not, do we have the ability to hire people? And then I think also like getting creative with where you look for funding. So I think like there's some things that you can easily do, like investing in a subscription to Foundation Directory Online. It's really great to like research foundations. It's really great to research opportunities. I think most states have kind of like local websites that kind of compile grant opportunities. Those things are relatively inexpensive to sign up for and definitely like good for new opportunities. I think following foundations and funders on Twitter is great. Signing up for their emails. A lot of like the really big funders have all sorts of like collaborations and pooled funds that they do. And so I think it's really like, it's helpful to follow them because they'll always be announcing them, blasting them on Twitter because they want all this credit for like their good work. And so I think it's like really great for identifying those opportunities, asking around, using your networks to ask like where other folks are receiving funding, like the people at CBOs on this in institutes like this. I mean, it was so great in person when we could like chat with each other about that, but just asking other organizations like you, who's funding you, and ask them like if they would be willing to make introductions to some of their funders for you. One of the things in New York is that our city council members have discretionary funding. I don't know if that's the same everywhere, but in New York City, every single year, the deadline was actually Tuesday, you can apply for discretionary funding through the city council. And we've received substantial support for our harm reduction work through council member funds, like several $100,000s a year just from city council members supporting things like overdose prevention and education, naloxone distribution. We received several hundred, like $100K a year for specifically like sex worker outreach services through our harm reduction work. And so I think like getting creative about like not just looking for specific like health department opportunities, but where there might be something else through the city that you could apply for or go after. And then I think also looking at like potential partnerships, like we have a partnership with Mount Sinai Health Systems, which is one of the largest hospital systems in New York City. The partnership is funded by the State Department of Health, and it's all about hepatitis C testing and treatment, but it has allowed Vocal to implement a robust hepatitis C testing program that also treats our participants. So we have a number of folks going through this program where they get tested, they test positive, and they're there on site. And we have a nurse practitioner that works for Mount Sinai, but is located at Vocal's offices and can prescribe hepatitis C treatment. They can also do buprenorphine prescriptions. And so we've been able to start inducting people into buprenorphine on site and also through our like mobile exchange that goes around Brooklyn. And I meet regularly with our partners at Mount Sinai to discuss opportunities and what like we could potentially go after. And having a large institution like that for especially things like that SAMHSA grant, well, not for that SAMHSA grant, but for like other opportunities, like having a large institution like that has all those resources, like we're going to do this application. It's like, great, like sign us up as a subrecipient and you go for it. I think is really helpful. And I think I'm gonna stop there and yeah, thanks.
Thank you, Zach. That was so many amazing points. And I'm so glad that you brought up kind of that creativity in funding and the sharing of where you're getting funding with other SSPs. I know that with some grants, there, you know, by definition, only so many people who will be funded, but we're a community, you know, we can learn lessons from other aspects of prevention and infectious disease and really be pushing in the same direction. Also, you know, I know of a SSP around me, and if anybody's in the room in the chat, you want to tell us if you got this grant or not, would be great, but applied for the city tricentennial celebration grant, you know, is saying we're part of the city too. And so, you know, really looking out for other grant opportunities that are outside public health. And there was something you kind of touched on too, for our bureaucratic friends, and I say that with most love as somebody who was up until very recently a bureaucrat myself, that kind of the right hand doesn't necessarily know what the left hand is doing. And it's so important. It came through in some of the panels yesterday where health departments, you know, we can kind of say, well, we changed the policy, right? Whether that's around funding or whether that's around Hep C treatment and the stipulations or regulations around that. But that doesn't necessarily mean that it has changed on the ground. And so having that strong relationship, the bi-directional communication with the programs, with the community, so you know when those policies are actually in play on the ground and when those policies are well-meaning but haven't succeeded. And so, you know, that's definitely something to keep in mind for our harm reduction bureaucrats like in the room. Thank y'all so much for all of those amazing points. There's some really great questions kind of coming in on the chat. And so if I could, I'm just going to kick these out to whoever is interested, I guess, in answering each first. From Morgan in Alabama, are there any tips for forming collaborative teams now in anticipation for more of these funding opportunities, similar to the joint effort between NASTAD and AIDS United, so that smaller organizations might not have to set themselves on literal fire the next time there are millions of dollars being tossed around? Amazing question, great point. Maybe I'll kick that actually directly to y'all in Florida because y'all had that really great, or still have that great network that you're building out.
Yeah, I mean, what we did here is just started having regular meetings, and you know, it was something that Zoom, you know, COVID and Zoom made easier for us because folks didn't have to travel from such great distances. But you know, we just would have regular meetings where we would talk about what each of the programs was doing individually and start looking for common ground, so that when grants did come out, when they were announced, we already sort of had an idea of what folks needed funding, since almost all of them were operating with little or no funds. You know, and that's kind of sort, you know, that is how we started. It's just, you know, let's get together, let's talk. As I said, you know, we started to identify who's best for this grant, you know, who was best for the behavioral health COVID outreach grant. Well, you know, we were doing a lot of outreach for sex workers in Tampa, Orlando, Jacksonville, and the grant just kind of fell together. And SSP, which is one of our organizations, SSP Behind Bars, they got the funding, and I really think that one of the reasons for that, and one of the reasons for the other grants we've been getting is that cooperative nature, the collaborative nature. We're not just standing up one program, we're also involving everybody else throughout this state, and whatever technical assistance or whatever best practices we're learning or sharing from folks, we involve folks in that so that we kind of look good to funders, I think. We had a call with Comer Foundation, and Tyler, I forget again how many, we had like 16 or 17 programs on that call, from across the state, from Tallahassee, from Miami, from Orlando, from Duval and such. So it's just start small, and it was also like needed because we're also isolated. Even before COVID, the distances between us, to have those mutual aid meetings and to just talk with each other and be there to support and listen to each other's problems, this can be incredibly helpful, whether or not you're applying for funding or not.
Yeah, I just want to add to that, Tim, is, what we talked about grant writing and how that's a daunting process. And so for us in Miami, we knew it was really important to work with Tim and the rest of the collective organizations to try to facilitate as much of our grant writing knowledge as possible by reviewing grants that were going in after these meetings, saying, hey, you want to reach out to us and have us review your grant or provide in-kind effort for data collection, because we run on a statewide data collection system that we built here at the university to offer free access to data collection for the programs, where we have standardized reports that get fed back every week to the programs, monthly reports. So it makes grant reporting easier by having a standardized system across all programs. And when we have a grant like SAMHSA come together, where they're asking for all this data up front from all the programs, we can pull that right from the start and have the information right away through the network of data collection. So when we get grants funded, we want to then use those grants as a learning opportunity to, maybe there's language in that can be recycled and reused for other grant applications moving forward. And so having a repository of grants, just have that open and accessible for people to review and use and move forward with, I think is a really helpful thing to have, at least for us in the state here.
Yeah, thank you, 100%. And one of the things you mentioned about kind of pulling those grant writing resources that made me kind of think about is that can be a much more effective way than hiring a temporary consultant or a temporary grant writer who may not know, the realities on the ground, who don't know your community or your services. And, you can get a very boilerplate grant. Whereas if you're pulling together to bring that in, you have so much of that expertise. So I'd love to hear how y'all did that and see that it also seems to be kind of paying some dividends too. I'll open that same question on networks to Christine and Zach if y'all would like to touch on that.
The only thing I'll say is I appreciate the thing about like grant writing consultants coming up. As like a former funder who reviewed a lot of applications, it's like really obvious when it's a consultant writing that who doesn't know your organization, doesn't know your work, doesn't know harm reduction. I know it can like sound like such an easy way to like send off a bunch of proposals, but like it's very obvious. And so I think like building the capacity to do some of that grant writing in-house using resources like the amazing NASTAD grant writing toolkit that was released a couple of weeks ago. Like using those resources that are like made by folks in community, like our community, I think is a much better way to go about that than outsourcing to folks who, unless you're outsourcing to like, a person in harm reduction who like knows what the fuck they're talking about. Otherwise, it's just like not going to be super useful.
Yeah, and I don't think I really have much to add to Tim and Tyler, but for folks in the South, where programs may be a little more sparse, it might be worth sort of taking a regional approach to your networking, and developing sort of a coalition among like a regional group of folks and seeking opportunities that way when they present themselves. So don't feel necessarily limited to folks in your state, especially if you're the only game in town. You know, start connecting with like-minded folks and see what you can make the case for.
Definitely. And for some of us who are in states that have that kind of local ordinance structure, right, our programs aren't confined to our urban areas. If you're in New Orleans, you can't provide SSP or certain services in the parish in Metairie, but that doesn't mean that people from Metairie ain't coming to the Syringe Service Program. That doesn't mean that people from Mississippi aren't coming across the border. And so building out that kind of regional support structure means that you also understand your community that you're serving a little bit more too, and really get some of that information from where folks are also coming from. Frankie in Virginia had this question. I'm familiar with an authorized Syringe Service Program that's funded by Virginia Department of Health. Because their funding source, this particular SSP is restricted to specific sites. Have other SSPs experienced this barrier, and what have you done about it? So I think that, I don't know if y'all have experienced that, about being kind of grant locked to a specific site or distribution style.
Oh, you're gonna go, Christine or Tim? I'm off mute. I'll just go. I know. So, like in New York, like it's not uncommon for the city or the state to release RFPs that are like to a specific neighborhood or area within the state. I think like something we haven't really experienced is like an existing contract, like or like entering into a contract or grant agreement without knowing that it's going to be site specific. Like for example, at the end of last year, the city wanted to like launch harm reduction vending machines, but they wanted to do it in like very specific zip codes. And so they released an RFP and they were like, here are the 10 zip codes across the 5 boroughs that like you're allowed to apply for a machine. And it was like, you know, matched up with like overdose data for the past couple of years with areas that are seeing the highest rates. And so, I mean, like we've seen stuff like that. And we only go after those if it's like areas, zip codes in Brooklyn where we like provide services and we know the community knows us. And so they would trust us or something like that. But that's the only time that I've come across in my work.
I want to speak more to getting around stupid rules like that. You know, and this is where data collection comes in. Like if, you know, pushing back on having to collect a zip code of a participant, you know, is a positive thing to do, or at least having to share that with funders or with anybody. You know, I think we've already seen problems in New York with the SIF, you know, around them collecting zip codes and the community there being not happy that they were seeing folks from other zip codes come into their community to use the site. And it's something that you know, we hear in the South all the time from the programs. Oh, you're going to open up a program in Jacksonville. That means that you're going to call, you know, you're going to drag people in from all over Northeast Florida. And, you know, it's like, so don't collect zip codes, you know, apply for, I applied for a grant in Jacksonville where I had to identify the zip codes we were going to do Narcan distribution in based on overdose data from the Department of Health. And it's like, sure, I applied for that grant. Sure, I put in those zip codes, but is that where the folks are doing outreach? No, the folks are going to where people are buying and using, you know, and pushing back against those rules to say, you know, you may collect the data for the zip code where the overdose is occurring in, but you're not collecting the data where the person is purchasing the drugs, or are you collecting the data where the person is coming from to use the drugs? And, you know, so rules like that need to be challenged. They need to be kind of, you know, and then they need to be worked around. You know, don't collect on any data. Don't collect any data, you know, that's gonna give you problems in the future. it's just something that's not advisable for me in the 30 years I've done it. I've done harm reduction work. It's like I just don't want to call attention to those things. And one of my stock responses is, doesn't HIPAA prohibit me from collecting that data on people, especially in rural areas? That's all. I mean, look for ways to subvert these dumb rules that folks come up with that may be gray, but are necessary. Our folks are transient. If there's a drug bust in one community, they're going to move over to the next one. It doesn't mean that the data that the state has or whoever is even current. God, sometimes getting, and anyone from the state of Florida on here, I'm sorry, but sometimes getting data out of you guys is like next to impossible. It's why we're very happy that Miami is going to be our data collection point and hold that data so that we don't have to file forms to get data back from the state. Our data that comes from our participants, data that belongs to our participants. So I could go on about frustrations about where people should do this work, as decided by folks that aren't in the street doing it.
That's why
Yeah,
it's so important. Oh, sorry.
Sorry, I think all that I would add to that is, if we're talking about even more granular than zip code level, specific sites within your community, I would agree with Tim, like start advocating against that now. The types of, like, there is some data that you can't, like, collect data that supports your argument, collect sort of, information from participants around where services would be more convenient, why this is an inappropriate location, maybe partner with, a local university or something to do some sort of like survey, like community survey or environmental landscape or something around where folks actually live, congregate, like could use services versus where they're being required to put them. I know, many years ago, DC also had, like Martin is bringing up, also had some of these within a certain number of feet of a school or and there are charter schools in row houses in neighborhoods. I mean, so they did a study and found that the only place under these regulations that you could have an SSP was in the middle of the Potomac River, right? So being able to make those arguments and advocate as much as you can that this doesn't make sense, this is why, and this is where we actually need to be, and not be limited to certain sites, but have the flexibility to move as communities may shift and change, is incredibly important for the services to be effective, or else you're sort of spinning your wheels for no reason and making them see that that's sort of a waste of money, resources, time, that sort of thing.
Yeah, and for us in Florida, it depends on the county. Every county is interpreting laws differently and implementing the laws differently. And so there's places, I think like West Palm, where they have to say, we are going to these locations or get these locations approved by the county before they go to those locations with their mobile unit. And like, that just kind of defeats the purpose sometimes of the mobile unit, right? And so we're lucky in Miami where we can go and move the mobile unit where we want to move it based on where our participants are. But I mean, that's just, they're an hour up the road, right? Like, and it's in a different county. And so just even on that level, the counties are interpreting things a certain way and imposing their own restrictions. And so, for the collective side of things, what Tim's focused on is developing these model, MOUs and these model local ordinances based on ordinances that have been passed by other counties in the state. It's for us to provide an ordinance and say, this is kind of the standard ordinance. And hopefully we can write in, pieces to that ordinance that are beneficial based on what we see from other counties, like Panelists County that has no other supplies other than syringes. So you can't give out cottons or cookers or other pieces to the, that are important. And so we just, there's piecemeal legislation that creates piecemeal implementation. And so we're just trying to refute that and go against that as much as we can.
Definitely. I think this is also a big call to our policymaking colleagues in the room, the conference hall, about how important it is to have SSPs and the communities they serve involved from top to bottom when we're making these rules, because those are the folks, these are the communities that know the nuances of this, the nuances of not only doing drugs, buying drugs, selling drugs, all of those things that are so crucial to making a policy that will actually be effective. So speaking of those communities, I want to pass on this question from the chat. At what point do y'all talk to staff and community about a potential grant or project you might be considering?
Well, for us, we almost start from the community advisory board suggestions. What are they looking for? The staff we only have a few people on staff, so that's kind of easy, but we start right from there. What is the community saying that they need in what area? And that may look different in Marion County, which is, Ocala, horse country, than Miami or Jacksonville, or Lake County, which is an extremely rural county. Those needs are going to look different. So we start often from before we even see a grant opportunity.
Yeah, I would echo that. I mean, I think ours is more of like, we have a list of needs and wants from our participants and our community, and we kind of look for opportunities that will match those needs and those wants. Vocal uses a union structure, and so we have 4 core issue areas, and each one of them has a union. And so, I mean, that's a lot. And so those unions vote on like the policy that we're going to go after, what we're going to be advocating for at the city and state level, but also in the users union, information on what folks want to see at the syringe exchange. And so for us, it's very much they let us know, and then I get my marching orders and I go out and I find opportunities that will match what they're wanting. And then I think it's another thing we do is for example, the CDC Foundation recently had that RFP out for take home HIV test. And it was, it was oh, that might be interesting. But then when you look at when we talk to our participants there and look at actual data from our SSP, HIV isn't the main thing that folks are concerned about right now. And it's it's not the main infectious disease that's in our community and among our participants. I mean, that's really hepatitis C. Our hepatitis C rates in Brooklyn among people who use drugs are really, 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 really high. And HIV rates are fairly low. And so it's would this even benefit folks? And when you asked our participants, they were like, no, I don't want that. And so it's okay, well, then that's not necessary. So I think it's it's always, 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 always what they want and what they need.
Cool, thank y'all.
Oh, sorry, I forgot to touch on staff. The staff of our SSP, that's conversation number 2 is going to Arash, our amazing director of harm reduction services, and Paula, who oversees our SSP and our peer exchange program, and talking to them and all of our SSP workers about is this something that you think you can handle? Are we going to need more staff to do it? What's your bandwidth? Do you even want to do this? Isn't going to work. So it's kind of step 1, and then staff are always step 2, and then off we go.
Yeah, thank you. I mean, that's such an important point too, because if you're not checking in with your community and staff, you can run into this issue where you're stacking grants on top of each other. You have so much redundancy, right? And then that also may be a hindrance to other peers and SSPs in your area. So really, pulling through some of the themes I think that y'all have highlighted about working together, about being open and transparent, and letting the staff and community guide you. So that kind of rounds out our chat question. So I want to, as we have a little bit more time, if anybody does want to walk up to that lonely mic on the podium in the front of this large conference room and kind of queue up ask questions. Maybe in the virtual space, you can raise your hand and I can call on you. We'd love to get some of y'all's questions. What has been brought up for y'all in this space? Now that everybody's drank some more of that Hilton coffee.
I want to touch, while we wait for someone to put their hand up or something, touch on something we haven't talked too much on, but Christine did touch on it, is funders in national organization and health departments understanding different structures of organization for syringe services programs and harm reduction programs. Many of us, in myself, I've never worked in like a corporate structure of an organization. When we applied for our first grant through Gilead Compass, we had to identify an executive director, and we didn't have them. We just attached labels to people as grants require it. We were just, Tyler can attest to this, my pushback when for the SAMHSA grant, we had to identify somebody as a peer. And I'm like, what the fuck is that? Can someone please define what a peer is for me? And Christine, I think, talked about, was it you, Christine, that talked about that yesterday, I think? Or no, it was Maya Doe-Simpkins pushed a lot back about, peer and what that requires somebody to do. I work as a peer because I work as a defined peer because I'm somebody who likes to use drugs. I like to inject methamphetamine. It's fun, so I'm a peer, but am I a certified peer? Am I a peer that SAMHSA would agree to on this new NOFO from SAMHSA, where they're going to have to verify the credentials of somebody working in harm reduction? It makes my skin crawl. But for larger organizations to understand that these structures, don't work for us, and to figure out a way in your grant proposals that you can actually support us in the work we do and how we do it. We've been doing it for 30 years, to federal funders that may be listening in or may view this recorder. We've had leadership in harm reduction for 30 years, and you're all late to the game. So please accept our structures and look at them. And lastly, in that I'll say, if I read the word innovative in a grant, a NOFO, one more time, I'm going to tear my hair out. I do come from a state where there's a lot, New York, there's a lot going on there, and innovative in New York is not innovative in Florida. I mean, innovative in New York is a SIF. Innovative in Florida is a street-based Narcan outreach program. There aren't very many of them, so when we're applying for those grants, we're often, we read the NOFO and we're like, we can't compete with this, we just can't, and it's pretty depressing. It was pretty depressing, Tyler. What was that stupid form I had to fill out for the SAMHSA grant, where I had to put my credentials down and my contributions to science? My contributions to science is I took part in the first HIV vaccine trial in New York City when it was happening. I don't have any published papers. I don't have letters after my name, and a lot of folks in harm reduction don't. We got our experience and our expertise somewhere else. And so please respect that if you're a funder. Get to know us. There are lots of organizations who've done that, and lots of organizations who've done that to good effect. Tides, Comer, Levinson. They respect our lived experience and our living experience, and don't discount us. We're pretty damned effective, I think. Look at, as Zach said, look at the HIV rates in New York City. It's not because the government stepped in and did syringe exchange and funded it well for the 90s and 2000s. That's recent. But I'll stop now.
Amazing points. I think everybody in the chat also, lots of capital letters and exclamation points on all those. And I think what you said about peers, what Maya said about it yesterday, is so crucial. How do we define that? What does that take away from folks who do use drugs, who are still in these spaces? I think about that a lot when you're in the conference room, both as a community member, but then also talking about kind of the vague community members. But who is that? You know, is that you when you're in the conference room, or just you when you're off the clock? And so how we kind of draw those lines. There's a good conversation happening here kind of about health department centered harm reduction. And it's making me think of this kind of saying, right, if you build it, they will come, and how that's not always true, right? We see programs like this get built all the time, and then a year or two later, why aren't people coming, or why does nobody seem to want what we built? You know, so how can not only health departments, but maybe newcomers to the game, what advice would y'all have about that, about really integrating community voices or voices of people who are served around a mobile unit that has to be run by the health department, or you have to do your SSP at the county health unit? Maybe Morgan just actually answered that starts by asking the people what they need.
I was just gonna say that. Thank you, Morgan. Just start by asking what they need, but also, in approaching health departments, start by asking them what they're actually trying to accomplish. If what they're trying to accomplish is data collection and reporting, that's one thing. If they're actually trying to accomplish reductions of infectious disease, soft tissue infections and such in our communities, then maybe they should approach the way they're doing services in a different way. Most of our participants in Florida don't want to approach those vans. They're stigmatizing if they're in communities, and you've got, your logo splashed across the side of it, and everybody knows it's the syringe exchange van. People that are using aren't going to go up to it because they don't want to be identified within their community with that. And folks that may be accessing those healthcare services, that need those healthcare services, that aren't users, aren't going to go up to it because they know it is a syringe exchange van. So, what are you up to in a community, and how are you going to engage with the community to actually offer and complete those goals of your services, is essential.
Yeah, I think I would just add that it's really important to find your laws, or have someone find them for you and read them really, really closely. If your health department has to administer a program versus it having to be located at the health department, does that mean, you start doing street-based outreach with some backpacks in neighborhoods where you can reach people and folks don't have to walk through those metal detectors, or come to the health department that lives next door to the police department or has security that doesn't get it. If it's, we were talking the other day, and I feel like one of the best things a health department boss left me with was how important it is to read between the lines, right? And if it doesn't say that something is absolutely not allowed, if they just don't mention it, then do it, because that's their mistake for leaving it out of the law, right? So take a close read and see what kind of wiggle room you might end up having that you didn't realize and that no one else realizes either. There may be nothing, but you might be surprised what you find.
I think that's such an important point. And, kind of what Tim said in the chat, and I think that connects to what you said yesterday too, about what does a drug-free workplace mean? Does that mean everybody has to be drug tested all the time?
Now, my understanding is that it means that it's potentially important to have some written language in a policy and procedure, a very brief line about having the right to do drug testing, and the implementation is totally different. That doesn't mean you need to drug test anyone. That doesn't mean you should. That doesn't mean you start. It just means that somewhere in your books it says if we want to, we have the right to do so, and make sure your folks know that like it's not your intention to do it, that you won't. And that's sort of what I've seen folks implement around federal money and having drug-free workplace law stuff.
Yeah, and if I can plug kind of onto that, consistency, right? Like you don't want to make this policy just for your peer workers, because what happens when you're a peer and now you've been working for a few years and your direct supervisor leaves? Are you now no longer eligible for that because you have to take a drug test to then move into another level of employment? Do you get another background check there? You know, so really making that consistent so that folks can, when you hire folks, they can move throughout your structure because they bring so much knowledge, so much experience and expertise.
I think that's important, Alison, is to, you know, one of the things most of us are finding that is being required for 501c3s is, you know, these governance documents, bylaws, and anti-discrimination and sexual harassment and whistleblower policies and things like that, and making sure, going through and making sure that those policies are actually really inclusive and offer you, as Christine said, wiggle room between, you know, what's actually happening and what's required. Give yourself gray areas that you can defend yourself against. You know, I brought the one up that we have in our bylaws yesterday, where we won't discriminate folks no matter where they are in their path, what pathway of recovery they're on, or on their, maybe they're on their route to abstinence. You know, making sure that you don't limit folks with histories of incarceration in your programs, you know, and stating that outright. You know, we're not going to get the same sort of legislation that New York has about not asking folks about their histories of incarceration. We're not going to get that in the South. It's just not going to happen. We can't get that. We can't get that for peers. Like our exemption process for getting a peer approved to work for a program here, and not even work, to volunteer their 400 hours so they can get certification. You know, we're not going to get that here. So making sure that your policies and procedures are inclusive of that, so that when that comes up, you're like just demonstrating to folks that I'm not going to discriminate against you because of your history of incarceration. In fact, that's probably a diversity point that not many organizations talk about, or not many funders ask as a diversity point. That's an expertise, like navigating the carceral system in this country and actually getting back out onto the street and like making your life work. That's like a skill set that not many people have. And that's why we see so much recidivism. Employing those folks and getting them to like help design programs to keep folks out of prison. You know, making sure that you're not discriminating against sex workers, and pushing back against the federal requirement that like all sex work, you know, that you identify all sex work as trafficking. It's not. You know, it costs us some partners in Florida when I insisted that sex workers be at the table of the collective, but I wasn't, you know, I'm sorry, besides being like really afraid of Cindy Clay, you know, I'm just not going to do that. I joke. The first bar that I hung out in, we called the 4-H Club. It was homies, hippos, heroin addicts, and hoes. It's the community that we are. And if we're not very clear in our policies and procedures that we're not going to abide by these discriminatory rules, then we're not being real harm reductionists. You know, we're compromising something that we don't need to compromise. And we compromise so much. But yeah.
I mean, 1000%. It is now, well, 12:26 for me in the Central Time Zone South. Probably a different time for other folks, but I do not think that there is a better way to wrap up this amazing panel. I am so thankful to get to chat with y'all, and to get to see some of these other wonderful breakout sessions later, the closing panel. Just really appreciate y'all sharing all of your knowledge, and well, not anywhere near all of your knowledge, but all of the knowledge that you did share today with us. And thank you so much for everybody who is attending the SSP Institute. And I look forward to getting to talk to y'all, hearing more questions, hearing more answers later on throughout the day. Any final thoughts from the panel?
Thank you, Alison, and I'll see everyone in the bar in Puerto Rico.
Yeah, see y'all in San Juan, October 13th. Okay. Well, yeah, I mean, I do think that that's it. This is kind of the awkward thing about being in the virtual space. That was kind of the last little bit. I'm glad that Tim's beautiful. Is that a Siamese?
Yeah, she's a Siamese.
That last meow was the signal to log off, and we'll see y'all in the breakout sessions in about 15 minutes. Thank y'all so much.
Thank you. Good to see everyone.
Thank you. Bye, everyone.